Okay, I'm Melissa Call. I'm one of the social workers with the ALS Association, and I work down at the Penn Clinic. And Susan Schwartz will be joining me in a couple minutes also. And we're going to be talking to you about will I be able to stay at home? And some questions to ask and answer when considering mechanical ventilation. So there are many things to consider in attempting to answer this big question, will I be able to stay at home? And we're trying to present this information that addresses the realities of the care needs. And these issues need to be weighed along with the family supports, home situation, desires of the ALS patient, along with the capabilities of the caregivers. So the first thing we're going to talk about is skilled care. And first I'd like to define what skilled care is when we're talking within this discussion of ventilator dependency. It refers specifically to nurses. Some policies, including Medicare, will pay for skilled care for an acute episode or after a surgery, and these are considered nursing visits. Often when someone is receiving these nursing visits, they will also receive a home health aide that will be sent out for a limited time period. The type of skilled care that we're talking about when someone is on a ventilator is called shifts of skilled care. And you must ask this question directly to your insurance company if they covered shifts of skilled care. Medicare does not pay for shifts of skilled care, and home health aides that come from private agencies are not permitted to provide ventilator care. So when you're talking to your insurance, you want to find out, another question to ask, if shifts of skilled care are covered, how is the amount of hours determined? Will they be decreased as time passes? Is there a mechanism for increasing the hours? Do they have a case manager in place that you could be in contact with? Another possibility is transferring or substituting benefits. Some people have been successful in transferring benefits from facility care to home care. This is usually in cases where a company is self-insured. It cannot be done with Medicare, but it's something to look into if you have another insurance. And another area that needs to be explored is annual or lifetime caps or benefit amount. Is there a maximum or a limit on what your benefit will cover? Okay. And beyond what insurance covers, alternative funding via the state waiver program. So in Pennsylvania, we have the independence waiver, and this waiver is designed to serve technically dependent individuals, such as someone on a ventilator. Funding is shared by both the federal government and the state Medicaid agency. You must be financially eligible as determined by the county assistance office. The figures are roughly $1,800 a month income with no more than $8,000 in assets. And this figure is higher than what you need to be eligible for direct Medicaid. This program may also be used by patients that have maxed out of their private insurance through cap on lifetime benefits. And applying for a waiver program is definitely a process that you'd want to, contact your social worker to help you with. And training of non-skilled help in ventilator care, who can be trained and what will they need to do? Patients have had family members, friends, and privately hired caregivers trained to provide ventilator care. As mentioned above, an agency-employed home health aide cannot do the vent care, only nurses through an agency. And the training, remember, is not just the care capabilities, but knowledge to assess problems before they become emergencies. And let's talk about the availability of ventilator-trained nurses. This sometimes can be a challenge. The current picture, estimates are that about 20 to 25% of nurses coming to home care agencies have some prior documented trach and vent care training, and another 10% express interest. Training takes time to satisfy competency requirements. And when insurance pays, they usually reimburse at $45 to $50 an hour. The independence waiver reimburses at a rate a little bit lower, about $10 to $15 less than what private insurances reimburse, discouraging some nursing agencies from enrolling in the waiver program. and the financial considerations. So the cost of the skilled care, some ballpark figures. For trained vent nurses, an RN ranges from $45 to $60 an hour, an LPN from $40 to $50 an hour. Home health aides range from $22 to $25 an hour, and they would be able to assist with the personal care if it's not met through other county agencies. Privately hired live-in aid care ranges from $135 to $160 a day. And nursing costs vary depending on training, the amount of experience, and also geographics of the service area. As far as equipment and supplies, most insurances will cover the cost of equipment and supplies. However, there are exceptions. There are policies that have no or very limited DME coverage. DME coverage is the durable medical equipment. And also policies where needs can be met under another clause, such as the respiratory clause, rather than the DMA. So this is something that's important to check with your insurance. And there are policies that will not cover a portable ventilator. It's very important to explore your individual coverage to know if you have co-pays. These can add up month after month. Electricity and generator. Every home is evaluated by the respiratory company for adequate voltage to support the several machines. If changes are needed, these are not medically covered expenses, such as extra outlets. The home must have a battery-operated portable vent, the batteries being charged at all times. Many people feel that it's a good idea to have a generator for power outages as backup also. So as you can see, a plan for comprehensive funding must be developed. And we're going to switch.
So we had decided we would kind of split this, not realizing the technology involved in having to do this. So in describing the home environment, what kinds of equipment will be needed. Some of this equipment may already be in the home, and some of it is specifically related to going on a ventilator. So kind of made a list of, and it's not totally inclusive, but goes from a hospital bed, the ventilator, portable ventilator, suction machine, humidifier, supplemental oxygen as medically indicated, a pulse oximeter, nutrition supplies, and everything related to that, including gloves and tubing and trach replacements and gauze, communication system, power chair that hopefully has been accommodated for the ventilator, and the possibility of a wheelchair accessible van with ventilator outlet. There's a real need to evaluate the ability to get a patient out of the home, both for emotional well-being, but also for emergencies. So is ramping necessary? And this is a discussion that is usually begun separate from a ventilator decision, but how are you able to get out of the home? And if ramping's necessary, is it possible? I get really frustrated with row homes that are right on the sidewalk and we can't do anything. So we need to really have the time to evaluate what are the other options if ramping can't be done. Vans are available for purchase and for rental, and these resources can be made available to you through your social worker. I was just made aware actually this past week of a new van that has been developed that is handicap accessible from the ground up. It is not a converted van. It is specifically a handicap accessible van with a ramp internal that comes out from the van. It's quite interesting, and if you want more information, shoot me an email. It's susan@alsphiladelphia.org, and I will forward you what has been sent to me. What I was told also is there is going to be a dealer in the Philadelphia metropolitan area, and that the cost of this van is extremely competitive rather than buying and converting a van or even for some used van. So it looks pretty exciting. And someone would be able to drive their power wheelchair into whatever seat, like the passenger seat, and still have all the other seats available for use. So it's pretty exciting, actually. Since the patient's home environment must be supportive, the necessary adaptations need to be identified as early as possible. The patient must be able to use appropriate rooms. There needs to be a safe emergency evacuation route. The electrical circuits, as Melissa mentioned, must be adequate. And there needs to be storage space because there's a lot of equipment. And I know that our panel of caregivers is going to address some of these issues this afternoon, but sometimes the initial decision makes sense, and then you have to go through changes when you realize what the day-to-day routine is. Okay, so the daily schedule. I know one of the caregivers that's going to be speaking this afternoon, initially when her husband came home, she had typed out, I think just as a way for herself to be aware of what was using up her day, what she was doing in 15-minute increments throughout the day. So the schedule obviously is very specific to the individual patient's needs, but what we can say is that ventilator care does require awake assistance 24 hours a day. The other issues to consider, and I think if people have not had help in the house prior to making this decision, there's a lot of changes. There is a loss of privacy. It's been described to me by patients as it became Grand Central Station, because there were nurses coming in, there were respiratory therapists coming in, there were other caregivers coming in, and the door was never locked because you really couldn't take the time to go and open it. People would just come in when they were supposed to be there. There needs to be an organized plan for backup care. Caregivers, whether they're trained nurses or people you've hired privately, caregivers get sick. Caregivers can't get there. There's weather issues, so there needs to be a plan for what are we going to do if that happens. Lay caregivers need to be trained, and just like family members are trained, people can be trained that are not nurses to provide this level of care. And there needs to be, sometimes it's a separate person, most often it's the main caregiver, someone who can just keep record keeping, because supplies need to be ordered, scheduling of caregivers need to happen, so there's really kind of a separate job from the caregiving, but often it falls to the same person doing that. So even with a lot of skilled care provided, so let's say you do have insurance coverage, or you're on a waiver program, or you're getting help from the VA, studies have shown that the primary caregiver is providing on average 9 hours of care a day, even if all the other caregiving is in place. You have to think about it in terms of shifts of care. If you look at a shift of care as 8 hours, there's 21 shifts of care that need to be covered throughout the week in one way or another. And in studies where they've looked at people at home on ventilators, the number of individuals can be up to 35 different people providing care during that week of care. So sometimes choosing ventilation and being at home cannot come together. And the other option that needs to be looked at is, would you live in a nursing home that provides skilled ventilator care? This discussion should take place at the same time one is talking about choosing ventilated care. If coming home or being able to stay at home does not work out, or if it's just a decision that the patient, the family, and the caregivers cannot come together on. Nursing homes for ventilator care are not necessarily the nursing home down the block. These are specific facilities that provide ventilator beds, ventilator care. So it's really important to do some of this research prior to looking at this decision in terms of where might that nursing home be. Almost every patient that I've been aware of after they are vented in the hospital and things stabilize do go to a nursing facility for further training and to allow for the time for the house to come up to where it needs to be, supply-wise, care-wise, for the patient to come home. But that is not necessarily a long-term facility. That is for, and it obviously varies, the amount of time that someone might spend before they could come home. Who funds nursing home placement? Medicare really has a very limited role in funding nursing home care. It may pay for up to 100 days of care after a 3-day hospitalization, but Medicare's focus is really on rehab and short-term nursing home stays, not ongoing care. And this is true of most private insurances as well. So if Medicare pays at all, when that benefit is exhausted, it's either private pay or long-term care insurance, which not that many people have long-term care policies for a variety of reasons. But once someone is living in a nursing home, the facility will work with the family on applying for Medicaid. Medicaid in this country is the payer of long-term care. But there are implications of going on Medicare, both for assets and resources, and it is highly recommended that if a family is considering ventilation and the possibility of nursing home placement, that they meet with an elder care attorney to look at protecting what is referred to as the community spouse and the assets for, as been talked about today, a lot of potential out-of-pocket costs that will arise. We also talked about how once somebody is in a nursing home, there is equipment that insurance won't pay for. So if this is equipment that needs to be paid for privately, how to protect resources from that money necessarily going to the nursing home or being spent down before one's Medicaid eligible. Your social worker can definitely give you resources to finding elder care attorneys, and despite the name of elder care attorney, what their focus is looking at nursing home placement and Medicaid application. They can help develop a plan to protect resources. So these are what Melissa talked about and when I talked about, some of the kind of financial and nursing and insurance issues that we'd like to explore with you when you're looking at this. And I think really much of what everyone talked about this morning will really be further explored by the caregivers that have been gracious enough to come and speak this afternoon and really talk about, having made this decision and looking at all these issues, what are the issues that they are dealing with and how their experience can be very helpful to you. So, thank you.